Thank you. It's truly an honor to be here. I'm inspired by all the incredible women in this room, and I owe a lot of thanks to Teresa for the invitation. I have no related disclosures. So when I did my medical training in the mid-19 to late 1990s, the quintessential head and neck cancer patient was this individual. Elderly gentleman in his 7th to 8th decade. As you heard, heavy smoker, 3 to 4 packs per day, heavy drinker. The person I did not envision was Michael Douglas, or many of my non-smoking young pilots in their 30s and 40s. And this changing face of head and neck cancer has everything to do with HPV. Now, just in the way of some housekeeping slides, as mentioned, I'm going to talk about oropharynx cancer, kind of a throwback to anatomy, so just think about the area shaded in pink from the level of the soft palate to the vallecula. Specifically, when I say HPV cancer for this talk, I'm talking about tonsillar squamous cell carcinoma and base of tongue, or what we call lingual tonsils. Now, there are a host of different HPV viruses, over 180 subtypes. I'm very lucky in my field when it comes to doing research. The majority are specifically related to HPV-16. In the way of statistics, I think this is pretty sobering. Today, as we sit here at the DoubleTree, there are 79 million Americans actively infected, some of us right now. There are about 14 million infections per year, and in fact, at the end of one's lifetime, 80% of all Americans will have had at least one infection and never even know. We tend to be asymptomatic. We're just going to clear it in our own immune system. And at the end of the day, only about 10% of infections are persistent. Now, one of the main things I want you to walk away understanding is we are in the midst of an HPV oropharynx squamous cell carcinoma epidemic. As you can see, this is SEER data that dates back to 1988. I think I have a pointer here. This decline is the black line. Those are the HPV negative oropharynx cancers, our heavy smokers. That decline is thanks to some phenomenal anti-smoking campaigns. But we remain in this steady state, shown in yellow, because we have the increasing incidence here. This rapid upsweep is the HPV positive cancers. This is a fun way to look at it. This is from the CDC. We've broken it down by gender and state. The darker the shade of blue, the higher your incidence of HPV-induced oropharynx cancer. So I come from Indiana, where in dark blue it's one of the highest rates for men, as are the southern states for both men and women. And please realize this is not unique to the United States. We're seeing the same trend in countries such as Sweden. And here in England, they've broken it down by different HPV-induced cancer types, and hopefully by now, you can guess that this orange line is oropharynx cancer. For perspective, here's cervical cancer on the downward slope. 2020 is the year I want you to remember. 2020 is the year that the World Health Organization is predicting that HPV-induced oropharynx cancer will actually surpass that of HPV-induced cervical cancer. So for me, that was very sobering. I want you to also realize these are two very different cancer types. On the right is your traditional heavy smoker, elderly gentleman. Often these individuals come from a low socioeconomic status, much different than our younger patient population, many of whom are non-smokers, higher socioeconomic status, and thankfully they also are demonstrating a higher survival rate. One of the challenges, and I share this for primary care, is diagnostics. Again, it's usually not top on your differential for head and neck cancer if they're not a smoker. And many times these patients are asymptomatic because they either have tumors of unknown primary or a very small base of tongue tumor here, yet they're presenting with very large cystic masses, so they're often misdiagnosed initially as a branchial cleft cyst. Now, what are the risk factors? They have everything to do with sexual practices, and I'm sure this will be talked about later on. Early engagement of first sexual contact, oral sex, as well as immunosuppression, and please realize that includes smoking and marijuana. Now, certainly HPV oropharynx cancer is a male disease. Men are 6 to 7 times more likely to have the cancer than women, but we do have some data out there thanks to the National Health and Nutrition Examination Survey. Overall prevalence for oral HPV is thought to be about 4%, and just for frame of reference, it's about 43% for cervix. What's interesting is that a woman who has an HPV infection of her cervix is about 5-fold higher rate of having also HPV in the oral cavity or oral pharynx, but there's a very low concordance rate between the HPV subtype, and we're really not sure why. One of the common questions I get asked by a spouse or partner is, can I catch it from my partner? So I've just diagnosed a patient, usually it's a young man, with oral cavity or oral pharynx, I should say, cancer, and they want to know, should I go get vaccinated? Is this contagious? And thankfully, we have enough objective data to know the answer. We can look them in the eye and say no. This is a study that actually came out of Dr. Berlin's institution, Ohio State. They took 164 newly diagnosed oral pharynx squamous cell carcinoma patients, had them do a mouth rinse, and on the day of diagnosis, 61% had evidence of oncogenic HPV-16. That very same day, they rinsed their partners, the majority of whom were women. The incidence of oral HPV in that mouth rinse was only 1.2%, and in fact, that was no different than the general population at 1.3%. So no, assuming, and this is the key, assuming you are in a monogamous relationship that's been long-term, you are not at increased risk. The philosophy is whatever DNA was going to be swapped in your saliva already has been throughout the years. Now, our HPV-positive patients fare much better, as shown in this Kaplan-Meier curve, HPV-positive oropharynx versus negative. And in fact, in January 1st, when we introduced the new AJCC staging system, for the first time ever in my career, there is now a separate HPV oropharynx staging system broken out from the HPV-negative patients. So that really begs the question, are we over-treating our patients? Do we have the ability to de-intensify treatment? As of today, when we sit here, the answer still remains no, because we're still accruing patients for some phenomenal clinical trials, and we need further long-term follow-up. But we are all very optimistic and believe at the end of the day, for a subset of patients, we should be able to. This is not just my opinion when I say no, we can't de-escalate. This is put forth by the National Comprehensive Cancer Network, as well as my American Head and Neck Society. As far as the de-escalation strategies, there really are three. I'm just going to paint broad strokes. One is to give concomitant chemoradiation, but to reduce the toxicity of chemotherapy from switching from cisplatin, which is gold standard, to cetuximab. A similar strategy, again, still with concomitant chemoradiation, is to decrease the amount of radiation that's given. And then the third strategy, and the only one to include surgery, is that we treat patients up front with surgery. We then risk stratify based on their final pathology, and potentially they can be randomized to an arm with lower adjuvant therapy. Now, it's not as easy as an on and off switch, meaning just because you're HPV positive doesn't mean you're going to do fantastic and you don't have a 100% survival rate, and because there are a lot of confounders, the biggest one being smoking. And in fact, smoking negates any potential benefit that HPV provides, but it's not even that straightforward. We realize, thanks to some great work out of the University of Michigan and Frank Warden's group, that HPV copy number plays a role. We realize epidermal growth factor receptor also plays a role, and just to confuse the pot even more, all of these are impacted by smoking as well. So certainly, HPV, oropharynx squamous cell carcinoma, is my future as a head and neck surgeon, and it's the future for primary care. It's the future for all of our oncologists as well. What you're looking at here is SEER data projected through the year 2030, broken down by head and neck subsite. So this is other pharynx. Larynx is on the downward slope. Here is oral cavity. This is oropharynx HPV-induced squamous cell carcinoma. I won't say too much about vaccination because I know there'll be further talks on that, but we are all very excited about the fact that we do have these vaccines, and we are especially excited when they became FDA approved for boys. So hopefully today I imparted upon you the point that we are in the midst of an HPV oropharynx squamous cell carcinoma epidemic. Thankfully, these patients, assuming they're a non-smoker, tend to do better, and we're very optimistic that moving forward in the next 3 to 5 years, in a select group of HPV patients, we should be able to de-escalate treatment and toxicity. I thank you for your time.